Morning, everyone. My name's Ashleigh. My name's Ashleigh. I'm one of the psychiatry registrars here at Counties at the minute, and I want to talk about this research that we are planning at the minute, looking at patients in residential care and issues about capacity for patients in residential care to consent to their placement. Whenever I did my placement up in the inpatient unit for old age psychiatry, this was quite a common issue that came up, and there's lots of, there are legal and ethical issues around it. So before I get into the research that we're planning, just some people might not be working in old age, so just want to go over some of the concepts that some people might not be as familiar with. So when I talk about residential care, residential placement, it's kind of an umbrella term for these 4 levels of care. So rest home is the most basic level, so that would be people who are largely independent but just need a bit of extra support. Private hospital level of care is for people who need a bit more intensive support, usually around physical health issues, but often they can have like psychiatric or issues or dementia, but it's mainly focused on their physical health care. Dementia units, so we've seen that dementia is a spectrum, and most people are able to be managed at home in the community with packages of care and supports of family. But dementia unit is for those at the more severe end of the spectrum who just too unsafe to be managed at home. So they are locked units just for patient safety. And psychogeriatric hospital, so that is the most intensive level of care for people with quite significant psychiatric and physical health needs. Again, those are locked units. And I just want to describe, whenever I'm talking about capacity, so capacity is always decision specific when we're talking about capacity assessments. And whenever I'm referring to it, I'm talking about the capacity for patients to consent to their placement in residential care. If a patient is deemed to have capacity, it's very straightforward. It's their decision. Even if we don't agree with it or it's a bad decision, if they have capacity, they can make their own decision. If a patient doesn't have capacity, then one of 2 things need to happen for them to be in residential care. If they have an enduring power of attorney, which is someone that the patient has appointed to make decisions for them in the event that they lose capacity, that needs to be activated, and then they can make decisions in the patient's best interests. Or if they don't have an enduring power of attorney, then an application for a court order or welfare guardian needs to be made. And again, that assigns someone to make decisions for the patient in their best interest. If neither of those things have happened, then the patient is technically being illegally detained. We're kind of putting them in a unit, even if they're not arguing with the placement, if they're just passively assenting, they are being illegally detained. It's a vulnerable population. They've no safeguards in place to protect them, no one advocating for them, and as well for the staff have no safeguards because they're making decisions for the patients and looking after them, and they have no legal framework to actually say that they're able to do that. So this is the population that we're quite interested in, and in New Zealand we don't even know how many people would be in that group. So this is an audit that led to what we're planning to do. This was an audit led by Mark Fisher, and they looked at all 4 levels of residential care and whether the patients had capacity or not. They used the nurses' judgment, the nurses who was looking after the patient and knew them the best, used their judgment to decide whether they had capacity to consent to being there. For the ones that were felt didn't have capacity, they then went and looked and see if there was any legal framework in place for them to be there, so either the enduring power of attorney or a welfare guardian. And some of the results were pretty much what you'd expect. So for the rest home, obviously the lowest level of care, most patients did have capacity, and for the more severe end, the psychogeriatric patients largely didn't have capacity. The nurses found it most uncertainty to decide capacity in the private hospital level of care, but even with that uncertainty, they felt confident that about 60% of patients lacked capacity to consent to being there. And whenever we looked for the legal framework, about 1/3 of them didn't have anything, so that was 1/3 of the patients were in that illegally detained group. And if we extrapolate that to the whole of New Zealand, it looks like there's at least 2,000 people in private hospitals just being illegally detained. But again, that number is based on the nursing assessment of capacity, which isn't typically a nurse's job to assess capacity. So we don't know how accurate that is. We don't know if they are overestimating or underestimating capacity. So what we plan to do to try and improve the validity of that original audit and see how accurate those numbers are is to find out how accurate that assessment was by comparing it with a more formal capacity assessment. We're going to solely look at the private hospital level of care because that was where the nurses had the most difficulty, and so if there are any issues, it's likely to be found there. We're just going to take a convenience sample of private hospital residents and aim for about 60 patients, 30 with and 30 without capacity. And we'll take small samples from multiple private hospitals so that we're including as many nurses as possible, not just assessing one or two nurses' judgment. And then, so for data collection, just background demographics, details of placement, length of stay and things like that. And then we'll get their usual nurse to make a judgment of whether they have the capacity to consent to being in the private hospital. And that will be blinded until we can do a formal capacity assessment by a psychiatry registrar, which would be me. And I'll do the assessment by a semi-structured interview, which will adapt from the MacArthur Capacity Assessment Treatment Tool, which is a validated tool you see quite commonly in research about capacity. We're deliberately including patients that we know have capacity issues, so there are going to be some ethical issues. We would expect if patients don't have the capacity to consent to placement, they probably don't have the capacity to consent to taking part in the research, which HDEC, the National Ethics Committee, aren't a big fan of us doing research on dementia patients if they can't consent to the treatment. Unless we can show that there is a direct benefit to the patient by taking part, which we expect, well, we think there is. Just having a formal assessment of their capacity, assessment by a psychiatry registrar, we think that will raise any issues of capacity, let us go and see if there is a legal framework in place and get that sorted. So we think they would benefit from that, so hopefully we'll get ethics approval. So the hopes of the research, if we are able to do it, obviously the main aim is to improve the validity of the previous audit and find out how accurate those numbers are. But as well, I think it's just important to highlight this issue of people being illegally detained without capacity and placement, and just any research will hopefully highlight that. If down the line something does need to happen, as much information as we can get will help inform clinical processes, and I imagine some clinical processes in residential care will need to be looked at. And I think, like I said, it isn't really expected of nursing staff to be doing capacity assessments, but they are the ones looking after the patients, seeing them the most day to day, in the best position to kind of identify capacity issues, see any changes in capacity. So I think it's important that we're able to support them and identify if they need further training, so they feel confidence to raise any issues. So that was pretty much everything I wanted to cover. If there's any questions.